Hello, and welcome to the Rest, Repair, Recover podcast. I'm Susie Bolt. This is a space for anyone who's navigating chronic illness. We are here to share real stories, helpful insights, and honest conversations about what it really takes to help yourself heal a tiny bit every day. So whether you're in bed listening, you're on a gentle walk, or you're just needing some company as you go about your day, I'm so glad that you're here. So a very warm welcome to Dr. Sarah Glynne. I'm delighted to have you with us. Sarah, I've just realized that the name on your screen there says Christmas, which is quite funny. I think we should keep it. I like it. We're heading that direction.
How to change it? I don't know why it said that. Bit of a technophobe, sorry.
I love that. That's made my day. And we are here because obviously there are so many questions arising for women, particularly around what is going on with our hormones as a result of our post-COVID infection and everything that kind of kicks off within our system. So first of all, we've come to you because you specialize now in working with menopause. Now, if you're watching this and you're thinking, well, I don't think I'm old enough or at that point where menopause is my thing, we are going to be covering the hormone disruption in younger women as well. So don't switch off just yet. But first of all, let's just hear from you about how come you're at this point in your career specializing in menopause, and tell us a little bit about the work that you're doing.
Sure. So I'm a GP, menopause specialist, and I only started getting interested in the menopause probably about 2016, 2017, just very gradually. Took a sabbatical around that time, did some painting, thought that was going to be something I'd get into. That didn't happen. And then basically the COVID pandemic struck, which obviously, who knew that was going to happen? And I was following Louise Newson online on Instagram. And I remember quite early on, I think it was March or April 2020, she put a slide on Instagram showing the different effects of estrogen on cells of the immune system and its immunomodulatory properties. And it caught my attention because I did a master's degree in allergy a few years ago at Imperial College. And I'm quite interested in the immune system and how things work. And I think I just started reading about it. And I guess the good thing is that my interest in COVID and the menopause was evolving at the same rate as the pandemic. So it wasn't like I had 20 years of papers to try and catch up on. I could sort of keep abreast of what was happening. I think the other factor that fed into it was my husband, Paul Glynne, who I'm sure some of your patients have already met. He's seen a lot of patients with long COVID. And of course, for the first time ever, we were both working from home. So normally he does his thing, I do my thing, and we meet up at the weekends. But because we were both working from home and he was seeing long COVID patients a bit later on in the pandemic, I was telling him about the link with hormones. He was seeing patients. He was coming out saying, what do you think? And, do you think we should try HRT? And it just kind of grew from there, really. And my interest in the menopause has grown. I'm now seeing quite a few long COVID patients. My other special interest is breast cancer, which interestingly has some parallels, I think, with long COVID. They are menopause patients that have some quite complex needs. There are a lot of evidence gaps. In long COVID, it's more of a gaping chasm, I think, than an evidence gap when it comes to HRT. Yeah. I think both groups of patients are dealt quite a poor hand by the NHS and the healthcare profession. So it's just grown with that. And now I was working in the NHS until the summer. I no longer am. I was really struggling to make it work because the NHS, these 10-minute appointments did not work well for me. And it was getting very stressful. So now I'm working in London with Claire Mellon and Associates. And I've just taken on a position with Newson Health as well, and just as an academic role so that I can do some work in long COVID and breast cancer and other things that I'm interested in.
Amazing. Well, fantastic. It was funny because this morning I knew I was talking to you later today, and I was just thinking, isn't it interesting how, all women that have ever existed on this planet, if they were lucky enough to get to their 40s and 50s, will have gone through this massive change in their bodies. And that's all women ever in history. And yet, we are still in the early stages of figuring out ways to help. And I was just really struck by how insane that was. And do you think that there is a shift now that maybe long COVID has sort of brought it into the forefront a little bit more, that we need to look at this. We need to have a kind of package that's available to every single woman anywhere at any, at any point in the cycle that they realize, I need help with this.
Yeah, I mean, I think so. I think there's a lot of talk about over medicalizing the menopause, or, my mum went through it and she was fine, et cetera, et cetera. I would say, firstly, your mum probably wasn't holding down a job as well as a family, et cetera, all the things that, women do nowadays. But also, it wasn't really until the last 100 to 200 years that women were living for so long after the menopause,
Right.
only
Right.
because of medicine and vaccinations and antibiotics and better maternity care,
Right.
etc. All of these things are unnatural. They didn't happen naturally. It's because of all these things that we're living for much longer. So biologically, I guess we were never designed to live until we were 80 odd, fulfill our potential, and then we would, we've done our bit, we'd shuffle off the mortal coil. But now we're living for a lot longer. And so not only are we transitioning through the menopause, which in itself can have some quite debilitating symptoms for some women, but in terms of our long-term health, in terms of your cardiovascular health, your bone health, your brain health, diabetes, obesity, mental health, all these things start to deteriorate or are adversely impacted when your estrogen and your testosterone levels start to fall. So aside from diet and exercise and sleep and all those kind of things, actually, I do believe that hormone replacement is the best thing that women can do for their long-term health.
Interesting. Oh, okay. Because I know there is still a really big cohort of people out there going, oh, no, 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 it's natural all the way for me. Um, which isn't, obviously it's everyone's choice. And I think there's a lot of products out there that people say, oh, this is a natural estrogen. And I'm
Mm.
just curious, is there such a thing as a plant-based estrogen that will do what we want it to do in the body?
Not really. I mean, there are phytoestrogens, which are estrogen metabolites in plant-based
Right.
ingredients.
Like soya and stuff.
Exactly, exactly. And the evidence that they make a big difference is small, I would say. So I think really, if the issue is that your ovaries are no longer making the hormones that they used to make, then the only way to put those back is to give them in the form of HRT. And if you don't want to have HRT, you don't have to have it. No one's trying to force all women to have HRT. But I do think that doctors and healthcare professionals have a duty to be up to date with the risks and benefits of HRT so that women can be enabled to make decisions for themselves. It all comes down to shared decision making, doesn't it? And I think not engaging with menopause and not thinking about HRT and not thinking about women's health is actually really unhelpful to women generally.
Absolutely. I mean, one of the things that I've noticed myself is, maybe that's just because I'm a 50-year-old woman myself. We are talking about it a lot now, way more than was being talked about, even 10 years ago. So that in itself, you've got people like Davina McCall who's out there kind of weekly blogging about it on, YouTube and stuff. And it's great because I think people do need to see other people that they perhaps identify with or recognize, and they're going through it. And it's kind of leading the way for people to be much more able to put their hand up and go, I am feeling dreadful and my mental health is all over the place.
Yeah.
This could be menopause. This could be the hormonal shifts that she's talking about, which I think is
Yeah.
huge.
Absolutely. And interestingly, even, HRT is licensed to treat menopausal symptoms. It's not licensed to prevent future long-term health conditions. But I do think, even if women are transitioning through the menopause very smoothly, that's brilliant. They're in the
Yeah,
minority.
great.
Good for them. But they're still going to, HRT would still halve their future risk of cardiovascular disease, which kills, by the way, 7 times more women than breast cancer. It halve their future risk of osteoporosis, and osteoporosis kills about the same number of women each year as breast cancer. Emerging evidence suggests that it will probably more than halve your risk of future dementia. Alzheimer's,
Wow.
one of the biggest killers in this country. It's twice as common in women as men. There's no cure for it. It will reduce the risk of diabetes by 30%, meant all these major, major health problems. So again, I think it should be up to women. I think it's not fair to discriminate against women who are transitioning through the menopause very easily and say to them, well, I'm really sorry, but you can't have HRT. You're just going to
No.
have to accept that your risk of heart disease is going to increase in the future. It's your bad luck because you don't have any menopausal symptoms.
Right.
It's just a hormone. I think, women are intelligent and they are capable of deciding for themselves if the benefits outweigh the risks in their individual case.
Absolutely. I just had one of my students actually contact me recently and say, her menopause transition had been quite smooth. She had not thought about or needed to consider at the time she felt HRT, and she's just been diagnosed with osteoporosis. She's
Mm.
now done the research and gone,
Yeah.
if I'd known
Yeah.
more, I could have prevented this maybe, or at least taken a big step towards some preventative action. So I think that's a really great point. I'm really glad that you've raised that early on, because I think people are still a little bit afraid of it.
Yes.
Um,
It's just a hormone.
right.
That's scary.
Right. But we're afraid of it for lots of reasons. And, we can sort of explore that a little bit because, of course, in the past, it was linked to increasing your risk for breast cancer, et cetera, et cetera. So, but let's just cut right into talking about, some of the stuff that people are raising around long COVID. So tell us, first of all, and I know many people will know this already because we've already been talking about it for a good couple of years, but what is it that happens in the body when long COVID comes in, causes a disruption, and suddenly your cycle goes all over the place? What's happening? What's the mechanics there?
Yeah. Well, that's the $64,000 question.
Okay.
Nobody understands the pathogenesis of long COVID yet. There are lots of theories that I'm sure your clients will know inside out and back to front. Is it microclots? Is it histamine related? Who knows? In terms of hormones, I do think that the ACE protein, which is how the virus gets into cells, is expressed pretty ubiquitously throughout the body. It's not just in the lungs, and it's on the ovaries. And it's completely plausible that if the virus is getting into the lungs or the brain or the heart by hijacking the ACE2 protein, then it's presumably doing the same thing in the ovaries. And if it's infecting the ovaries and causing inflammation, then obviously the ovaries are there to make hormones, and it's going to cause impaired hormone balance. I think in younger women, and this is just a theory, I think in younger women, it's very common. Lots of women report changes in their periods after COVID-19 infection. But younger women on the whole, not always, their periods return to normal, and it's a transient or temporary change. And I think probably in older women who are in their maybe 30s, certainly 40s and 50s, if they are approaching the end of their reproductive lifespan, then the ovaries have a reduced capacity and are less likely to recover if they have an insult, after an infection. It will be very interesting to see over time some of my younger patients, and I've only got one that I think this has happened for so far, but it will be very interesting to see if some of them do recover after a while. So, for example, younger women who've had chemotherapy, that can stop their ovaries from functioning. But when they stop chemotherapy, their ovaries can recover. And I do wonder whether some women will actually improve with time. But I think a lot of women who are in their 40s and 50s, probably it won't at this point. In which case, you have to decide whether you want to take hormones or not to treat your symptoms and protect your long-term health.
Interesting. So actually, for me, my cycle, when I had it, my cycle was quite badly disrupted. And I just thought, oh, well, that's that then. I think, how old was I when I caught it? 47 when I caught it. But it did, after 6 months, settle completely back down. And I have maintained a regular monthly cycle, which is quite surprising for someone of my age. So I guess, if you're listening to this and you're thinking, oh, well, I still do have a regular cycle. Great. It's not necessarily a guarantee that it's going to disrupt you long term or perhaps, forever. So,
No, I would say that perimenopause, which is the time leading up to the menopause, so that's really the 10 years leading up to the menopause,
right.
perimenopausal.
Yeah.
The average age of menopause is 51. So from your 40s onwards. And you can have regular periods until quite late in the perimenopause. So for some women, changes in their periods are one of the earliest signs that their hormones are going a bit haywire. And for others, it happens very late. And actually, they get the other symptoms first, like or brain fog or mood changes. Presenting with depression or anxiety, in their 40s is quite common. And so I wouldn't, just because you've got regular periods doesn't necessarily mean you won't do well with HRT. You may
Oh,
not.
no.
You may
Just say, I'm taking some. I've already signed up.
Okay, good. Periods is one symptom of the
Yeah,
period.
yeah.
Yeah.
Although I think it's probably the one that most people are going to be making an assessment around their sort of their cycle health around, because it's one of the obvious ones that you're sort of used to noticing for most of your kind of adult life.
Yes.
Obviously, I know lots of people are talking about um, the fact that their symptoms become much worse as they move towards getting their cycle. Some people are saying after their cycle, they become much more unwell again. And there's all these other, absolutely the anxiety and the depression and all of the mood stuff that's going on is a huge factor. And a lot of people don't necessarily know that that is linked at the point, when they're in it, they're thinking maybe I'm just incredibly depressed. And I
Yes.
think it is really important for us to talk about mental health alongside, the hormonal health of the body. They are togetherly, tightly linked.
Yes, absolutely. There's a reason that the suicide rate in women is highest in middle age, in their 40s and 50s. I think it's this hormone imbalance and just hormones going haywire. And it's
Yeah.
very difficult in long COVID because many of the symptoms overlap with the perimenopause, and there's no
Right.
diagnostic test for long COVID, and there's no diagnostic test for the perimenopause.
Right.
So if you've got brain fog or anxiety or depression, or your sleep's gone up the spout, or you've got palpitations or joint and muscle aches and pains, etc., as a doctor, you can't tell whether that's being caused by hormone imbalance or not. And actually, the only way to find out is to give women a 6-month trial of HRT. And if
Yeah.
they improve, that tells you that there is an element of hormone imbalance, and then you've got something to work with. And if it makes no difference, then it's not hormones, it's another effect of the virus. I have to say, obviously, I see a very biased group because they're women who've come to see me in a menopause clinic. But so far, I don't think I've had a single patient that hasn't responded to some degree to HRT.
Fantastic. Well, that's really good and reassuring because I think some people think that if I start it, I have to take it, like, and I can't stop, I can't change. There's a
Sure.
sense of once I've signed the dotted line, am I in forever?
Yeah.
It's fine to start, see how you go and stop again, as with any medication, right?
Yeah, absolutely. I would say if you've been taking it for a while and you want to stop it, I'd stop it gradually because your body will have got used to the hormones, so you don't want to stop it too suddenly. But no, absolutely, over sort of 2 to 3 months, you can certainly stop your HRT if you don't want to stay on it. Not a problem.
Hmm. Well, that's reassuring to know. Good. Okay. So people that are listening, it's definitely worth experimenting with it. Don't feel like you need to sign up for the rest of your life. Because I know that actually that's not even recommended, right? Your GP will tend to say a certain period of time, years wise, and then
Yes,
hmm,
they will. I mean,
they
I,
will. If they're
I
not in your clinic, they will.
again, in my clinic, why would you stop? So, absolutely, if you only want to take HRT over the menopause transition, which is what it's licensed for, absolutely, you can stop. As soon as you stop, your hormone levels will fall. And with the years that pass, that will start, the inflammation will start to increase in your body. You're more likely to become obese, get heart disease, atherosclerosis, adverse effects on your blood lipids, your hair, your skin, your weight, all these things. When you whether you stop, whether it's a natural process in your 50s as you go through the menopause, or whether it's an unnatural process 10 or 15 years later because you've been taking HRT and then you decide to stop, the net result will be the same. Your body will start to change. So again, I think women, as far as I'm concerned, there's no limit to how long you want to take it for. I think if you want to take it because the benefits outweigh the risks, then you should be allowed to take it.
Great. Well, that's really interesting because I think when I spoke to my GP about it, having spoken to all sorts of different people, one of the things that he was saying was we kind of recommend around 5 years. And
Mm.
then, to slowly wean off because that's that big piece around exposing you to more risk of breast cancer still seems to be kind of haunting the GP surgeries.
The breast cancer myth just will not go away.
Right.
Let's deal with it. So,
Yeah.
okay,
Right.
so the reason HRT is linked to a possible increased risk of breast cancer was because the WHI study was published 20 years ago this year.
Yeah.
It was a very large study. It wasn't designed to evaluate the risk of breast cancer. It was designed to look at actually cardiovascular risk in women quite a long way past their menopause. So women weren't randomized in that trial according to their cardiovascular risk factors, sorry, according to their breast cancer risk
Yeah.
factors. They were randomized according to their cardiovascular risk factors.
Yeah.
So the data that was collected from that trial in terms of breast cancer wasn't randomized controlled data
Right.
for breast cancer. It was observational data that was collected in the context of a clinical trial. Um, In that study, and this message got lost along the way. So in that study, women who'd had a hysterectomy who didn't need to have progesterone, so they were only taking estrogen, actually had a lower risk of getting breast cancer compared with women who weren't taking any HRT at all. So taking estrogen on its own reduces risk of breast cancer by 22%. That message got lost, which is a great shame. There was a brilliant paper published not so long ago where they analyzed data, looked at mortality data of women just in the United States who had been taking estrogen on its own before the WHI paper was published because they didn't have a womb. And it followed them up to see what happened to them. And it's estimated that probably about 50,000 women died prematurely because they stopped their HRT because they wrongly thought it was linked to breast cancer. So they ended up dying of heart disease and osteoporosis and dementia and all those other things that could have been prevented or delayed. So that's estrogen. It doesn't cause breast cancer. Okay. In that same study, in a WHI study, in the combined HRT arm, so most women have got a womb, so therefore they have to take estrogen and progesterone. There was a very small, less than one additional case per 1,000 women who took HRT for 5 years. So very small, increased risk of breast cancer in the group that were taking HRT. And in fact, the risk was increased by a similar amount to the decrease in risk in the estrogen-only arm. That in itself is not proven. It is possible, again, there was another study that looked at this, and it is possible that the increased risk in the HRT users was actually an artificial risk because the risk of breast cancer in the placebo arm was lower than expected. So in other words, if this, I don't know if you can see this, but if this is normal and this is increased risk and this is decreased risk, right? So they thought that this was the placebo arm, normal risk of breast cancer, and this was the HRT arm, which was a higher risk of breast cancer. In fact, it was like this. This was normal, this was low. The other big thing to say is that 20 years ago, they were prescribing synthetic progesterone, which is fine. We prescribe it still a lot. It's in the pill if you take it. But nowadays, we prescribe body identical progesterone, which is very different. It's better tolerated. It has a superior safety profile. We've got data up to 6 years, no increased risk of breast cancer. We need some longer term data, but even if it did, the worst case scenario would be that maybe it was as bad as the old-fashioned synthetic progesterones, which is hard to believe, and that was very small. The final point I'd like to make is that no study ever has shown an increased risk of breast cancer death in women who take HRT. And in fact, there was a brilliant study published in 2016 that showed HRT is breast cancer is very common. So unfortunately, 1 in 7 of us will develop breast cancer at some point in our lives. It is inevitable that some women will develop breast cancer whilst they're taking HRT because it's common. That doesn't the HRT that caused it. And study showed that women who took HRT and developed breast cancer had a significantly lower risk of dying from it compared with women who develop breast cancer when they're not taking HRT. So in other words, if you're unlucky and you get breast cancer, your prognosis is better if you get it while you're taking HRT. You'll probably find it earlier before it's spread when it's more treatable. And in fact, early localized breast cancer is almost curable. It's got an excellent prognosis. So
oh my God, I am so glad we've tackled this, because trying to get a definitive bit of information out about this is, I think it's one of the most important things, because I know so many women are still haunted by this narrative.
Say no because of a family history of breast cancer, and it makes no sense.
Oh, that's so interesting.
Yeah, I mean, I had a patient recently who GP wouldn't give her HRT because she was adopted and he couldn't be sure that she didn't have a risk of breast cancer. So she didn't even have a family history and he still wouldn't give her the HRT just in case. It's absolutely mad. There is no increased risk of breast cancer with the body identical HRT. And what the media fails to report whenever it's talking about this is it never talks about the many, many benefits. So even if you accept the worst case scenario, because I admit it's not, I can't guarantee 100%, but the worst case scenario, as I say, is this sort of 1 per 1,000 women over 5 years may get breast cancer. They won't die of it, but they may get breast cancer that can be treated. But then the massive benefits in terms of reduced risk of heart attacks. From your 40s onwards, you're more likely to die of a heart attack than you are to die from breast cancer. Dementia, which will, is one of the most common causes of death in this country. Osteoporosis. Why aren't we worried about women's brains and hearts and bones and all the rest of them. It's not just about their breasts.
Right. Well, I know there was a piece this week. I think it was in the New Scientist. Was it the New Scientist? Maybe. Just saying, why aren't we giving HRT to all women? Why are we not doing that? And I think that the cancer thing still came up as a kind of,
People get stuck on it, and it's
yeah,
amazing. You look at this data and you actually follow it. And there've been some very, eminent doctors that have been involved with publishing these types of studies, and I'm very happy to share them with you later if you
right.
want me to send you some links, etc.
Yes, let's do that.
And it just doesn't make sense. It doesn't make
Right.
sense.
Mm. So hopefully people listening to this, or at least perhaps, if they are going through a really tough time and they're trying to work out, is this perimenopause? Is this, is this long COVID? It's all the same sort of thing. It's a disruption to the cycle, right? It's a disruption to the systems in the body. It's going to show up in a way that just looks like the same thing. Menopause, long COVID. I think it's the same sort of thing.
Yeah. Yeah. There are
Offering people some reassurance. It's okay to experiment with this. And if it helps, amazing. If it doesn't,
Exactly. So, I mean, obviously, everybody's different. So I think some women, by the time I see them, actually, the thing they're left with is perimenopause. And
yeah,
other symptoms, if they were there, have probably got better. I still class those as long COVID patients, because probably if it hadn't been for the virus, they might have transitioned through the menopause more naturally, more slowly. They'd have had time to adjust to it. They may or may not have had really, nasty symptoms. But because the virus has either triggered an earlier menopause or a more dramatic menopause, that's drop in their hormones has been more profound. It's therefore a consequence of having COVID-19 infection. And then there are the other women for whom hormone imbalance is a part of what's going on. So there are certain symptoms. So, for example, POTS, I think, is interesting.
yeah,
I think HRT can help to reduce inflammation, but I don't think that it can cure POTS. I think if you've got pericarditis, I think if you're desaturating on exercise, that's not a normal perimenopausal symptom.
no.
So clearly, if you're somebody who's quite complex, and I've seen quite a few patients who are quite complex, then HRT is not going to cure long COVID. But if you're functioning at a sort of, 20, 30% or normal, even if I can only get you up to 50 or 60% at the moment, why wouldn't you think that? Yeah. It may be enough to get you functioning again.
Absolutely. And so that then brings us to the point of, how do people get their doctors on board with this? What would your advice be? Because it's all well and good you going, they should try it. They should at least be allowed to experiment. But, not all doctors are up for that.
No, they're not. So be armed. And I think I feel bad saying this, because I think when you're suffering from long COVID, it's easy for me to sit here saying, oh, do your research, get all the things you need to do. Yeah. And some of my patients are literally, they can't get out of bed and they can't have a shower. So it's but I think if you can, or if you can get someone to help you, on the Balanced Menopause website, there's a leaflet that I wrote with Louise Newson about the link between long COVID and hormones. There's the Balance app, which is free to download. You can track your symptoms over 2 or 3 cycles. You can download a health report at the end, and you can take that into your consultation as well. I think if you've done all those things and you've made an effort to share the information with your GP and they've still fobbed you off, then unfortunately you need to find a different GP or ask to be referred to a menopause specialist, and hope that it's somebody who knows a little bit about long COVID.
Absolutely. And there are a lot out there. And I think most GP practices will have someone that's at least done the training, that's probably a bit more up to date than some of the other GPs. So it is really worth pushing for that, isn't it?
You have to. I mean, it's like everything in the health service. I think you have to push for it, don't you?
Absolutely. Okay, let's have a look here at some of the questions that we've had. I know we're sort of covering things in discussion as well. So the link, we've sort of just touched on this with you talking about POTS, but people's experience of the dysautonomia, that dysregulation of the autonomic nervous system, and the link with estrogen as people head towards the end point of their cycle, the symptoms are getting worse. Can you explain a little bit about what might be going on there? Why is that happening for people?
That's really interesting. And about 3/4 of long COVID patients say that their long COVID symptoms, whatever they are, dysautonomia or whatever's going on, is worse the week before your period, which interestingly is when your hormone levels, your estrogen, is at its lowest. Yeah. And estrogen, as I said, it has lots of effects, and lack of estrogen causes things like brain fog and mood and palpitations, etc. But estrogen also has lots of anti-inflammatory properties and immunoregulatory properties.
Wow.
And I think it has a really important role at I don't know, boosting the immune system or suppressing inflammation. And in fact, that's probably why women are 2/3 less likely to die from acute COVID than men, because our immune response to an acute viral infection is different to a male immune response because of our hormones. Um, and so in terms of, obviously, if it's a symptom that's directly related to estrogen, then obviously if your estrogen level is low, your brain fog might be worse, or you might feel low. It's very common to feel a bit down, a bit depressed, etc., before your period. But I think even symptoms like dysautonomia, or perhaps if you've got pericarditis and chest pain due to inflammation, again, if your hormone levels drop, you lose that anti-inflammatory effect. And so again, I assume that's why those types of symptoms also get worse just before your period.
Oh, interesting. And what about those who, on the other side of that cycle point, say that they're feeling worse on the other side, in the few days post, the end of their period?
The problem is in the perimenopause, your hormones are all over the place. They could be doing absolutely anything on any given day, which is why blood tests are so useless, because you can do a blood test and it comes back often as normal. Sometimes it comes back as high, and that could mislead people into thinking, oh, well, it can't be my hormones then. Or their doctor will tell them, well, it's not your hormones because your blood test.
Fine.
That's rubbish. You've just got to speak to women, and it's really obvious. So I'm not sure. I think probably different things are happening in different cycles in different patients.
Yeah.
And some women notice, for example, they might get symptoms mid-cycle. It's another common time, which is actually when the LH and the estrogen are quite high. For other women, it's quite low. Things like migraines, for example, very common in long COVID. That is to do with the hormones going up and down. So it's not whether you've got a high level or a low level, it's whether it's going up or coming down that seems to trigger the hormones, which again is why they get worse in the perimenopause. Endometriosis gets worse in the perimenopause because you go from having a regular cycle and a predictable pattern to having a very irregular, unpredictable pattern. So anything that's related to hormone fluctuations is going to get worse in the perimenopause.
So actually, you just mentioned endometriosis there. And I know this is another one of those things that's really worth digging a little bit deeper in, because a lot of people are told that they can't take estrogen if they have endometriosis because it would enhance the thickening of the lining of the womb. So where are you at with that? Is this another myth that we can sort of expel? Do people only have to take soya products for the rest of their lives? Or
It's another myth.
there we go.
It's interesting. Some of my endometriosis patients, we feel anxious about it. And generally speaking, any symptom that gets worse when you start HRT, be it so headaches, migraines can get worse when you start HRT. Endometriosis can get worse when you start HRT. Histamine intolerance, possibly long COVID. I was quite worried about that when I started prescribing HRT for long COVID patients. Any symptom like that, the strategy is always to just start lower, go slower. And you could introduce it really gradually. It can be very frustrating for patients with long COVID because if they've been feeling unwell for 12, 18, 24 months, they want to get better really quickly. They want to feel like a bit.
They don't want to get worse.
They get worse. So it's annoying because it takes longer. Obviously, the lower the dose you start with, the longer it takes to get to where you need to be. But it's really important because if you can just get your body used to it gradually, then over time you can build it up so that your body tolerates it. And then you get to a point where your hormone levels are very stable as opposed to the perimenopausal bouncing around all over the place. And again, your symptoms will settle down. If you've got endometriosis, and you're taking progesterone, that protects, you're not going to get a thicker and thicker and thicker endometrial lining. We never prescribe estrogen without progesterone to somebody who's got an endometrial lining. And for endometriosis patients, even if they've had surgery, they often still take progesterone for that very reason, because we can't guarantee there aren't endometriosis deposits elsewhere in the body that haven't been removed. And we want to make sure that they don't cause problems by giving estrogen on its own. So the strategy is broadly the same. It's just lower, slower. And in fact, some of my patients, we've been very anxious and started them off slowly and they've been completely fine. Others have needed that start low, go slow strategy. So until you try it, you won't know.
And just out of curiosity, what is the lowest dose that you can start someone on? Like what's available out there? How low can you go?
So the lowest that goes, so I really like patches for this. And I think if you're someone that's sensitive to hormone fluctuations like migraine or endometriosis, I think patches are much better. They're a slightly more steady state in their hormones compared to a gel. A gel you apply daily, so it does go up and down a little bit. And if you're super sensitive to hormones, that can be enough to trigger your symptoms. Whereas a patch releases a steady amount of hormone over a 24-hour period. So they're good for that reason. And the other reason is you can cut them in half and you can cut them in quarters. So if someone's very anxious or if someone is struggling, you could literally get a 25 microgram patch, which is the lowest dose patch. Right. Normally cutting that in half is adequate. If someone's really anxious, I've never had to do this clinically, but because some patients are really anxious about it, I've said, look, start with a quarter of a patch. Then it's a smidgen of estrogen.
Yes.
So just have a smidgen for a few weeks. And then and that's the other nice thing about patches is that the patient then has control over how much she has and how far she goes. So I say in every 2 to 6 weeks, if you're feeling well and you're feeling confident, you go up by either a quarter of a patch or a half a patch, depending on how quickly you're going. And if you're not ready to go up after 4 weeks or 6 weeks, just give it another couple of weeks. Everybody's different, so you have to wait and see how people get on with it.
And the sorts of things that people are looking for, the sorts of positive improvements will be what? Just for example, a lift in mood, a lift in what? What sort of things will they notice?
So I always say to my patients when we're starting HRT, it is a bit of a journey. So no matter what dose you start on, if you come back in 3 months' time and tell me you're feeling, let's say, 30% better, that's a win. And then it's going to take 6 to 9 to 12 months to get it right. And then as you get older, your hormones will continue to change. So you're going to need to have it reviewed at least once a year. So I always say the biggest tip I could possibly give is to persevere, because I know so many women that they try something, they get a side effect, or they're a bit disappointed it didn't really do anything, and then they stop. And that usually means that either they weren't on a high enough dose, or they were on the wrong type of HRT and they weren't absorbing it, and therefore they didn't feel a benefit, and no one thought to check their blood hormone level to see if they were absorbing it or not.
Right.
So yes, it can take a while, and you do have to be patient and you do have to persevere. But I say, even if it takes 12 months, you should notice an improvement. You should be improving the whole time. And it depends what your symptoms are. If your symptoms are headaches, if your symptoms are brain fog, low mood, sleep, it will gradually be improving that whole time. And it's really interesting. I know from my own personal history. So I started HRT about 18 months ago because I started getting migraines, and I used to get migraines at puberty and I grew out of them. And so as soon as I started getting them, I thought, and that was, and, for me, that was my first sign of the perimenopause. That was my first clue that my hormones were starting to change. And I had exactly that experience. I started on a 50 microgram patch, didn't really do anything. I was a bit, I went up to a 75 patch. Actually, my migraine stopped, but I was getting an awful lot of headaches. Added in some testosterone, my headaches went. Amazing. Got up to 100, my energy levels came up. And so it's been a work in progress really for about 12 months. And I thought I'd got it right recently, and then obviously something's happened because they've all gone up the spout again recently. So now I need to up my dose again. But that's the point. You keep going with it until you get it right.
I guess that raises the question for me, and maybe for you too. Is there ever a point where too much? Is it ever too much? Does it have a negative impact if you're having too much in the body, or does the body just jettison anything it can't use?
Yeah. So if you were having too much estrogen, yes, it could potentially cause heavy periods or headaches, or might make you feel nauseous, but it's certainly not going to cause any long-term damage. And I've never seen it in any of my patients. I've never had that problem. And in terms of harm, if you think about it, with HRT, we're trying to get blood hormone levels in the range 250 to 1,000. So we know that if we can get it up to, 300, 500, that's going to protect your future bone health. When you are premenopausal, maybe when you're ovulating and you've got a lot of hormones, your estrogen's probably going up to about 2,000 or 3,000 in the middle of your cycle. When you are pregnant, your estrogen goes up to about 20,000. And you didn't die of that.
No. Estrogen poisoning on a death certificate.
Exactly. So the worst case scenario is that maybe, so for example, say you're one of those patients that I don't know yet, maybe at some point your body's going to start to recover. And actually, as your ovaries start to make estrogen again, potentially at some point there may be a patient that says, I don't know, I've started getting headaches, or I've started to feel a bit nauseous. if that's the case, I do a blood level. If their estrogen comes back as 3,000 or 4,000, we'll just stop the HRT, we'll wean it down and stop it. It's not going to cause any damage. And so far, I've never, ever seen that. But I'm just saying it's not something that women should
Great.
do. Yeah.
Great. Oh, that's really reassuring, I'm sure, for quite a lot of people. Because of course, when you see that, as with any drug that people are prescribed, you'd prefer to be on the lowest dose that's going to help you. And then what happens if you have to take this much? What's the impact here? Nothing very much. Great. Okay.
And that's the other thing as well, is I never get hung up on what's the external dose is, because we're all
Yeah.
different and we all absorb it differently across the skin. So, for example, I could have 3 women in front of me, and maybe they've all got a blood estrogen of 500, but one's using a 50 microgram patch, one's using a 100 microgram patch, and one's using a 300 micrograms twice weekly. But their blood hormone levels are the same because they've got different skin. So it doesn't matter what's on the outside, it's what's getting through that counts.
Interesting. Oh, that's fantastic. Because actually, I know when I went and had my patches prescribed, I wasn't really told this. So it was kind of,
People,
well, 100, what do I do?
they start to worry that their dose is getting too high. And you're sort of saying, well, no, because apart from anything else, perimenopause is a clinical diagnosis. And if you're telling me that you've still got symptoms and you're getting headaches and your symptoms are worse just before your period, or you're getting night sweats, those are really big cues when I'm taking a history that makes me think you've clearly not got enough estrogen. And I don't
dose.
Yeah. And I don't care what your blood hormone level tells me, we're going to go up on the dose until those symptoms resolve.
That's really reassuring. I'm very pleased, just from a personal perspective, that we're having a conversation. So I want us to pick up the piece around histamine, because I know for so many women, the histamine issue, especially, long COVID, so most of us had never even heard of the concept of mast cell activation syndrome.
Yeah.
And, to understand that histamine is a really big feature for a lot of people, and it can create symptoms, and it's all tied in with what's going on with the cycle as well. Tell us a little bit about what you're learning around histamine and its relationship to the hormones.
Yeah. So I certainly see a lot of patients with histamine symptoms. Whether it's mast cell activation syndrome or not, I don't know. I know there was a study published by Afren et al. Sort of quite early on, that demonstrated there's a significant symptom overlap with patients with MCAS and long COVID. I think that's a little bit difficult, because I think if you take any multi-system disorder and compare symptoms, there's only so many symptoms you can have. So I don't know that proves it's mast cell activation syndrome, but I certainly think there's something going on with histamine. And actually, this links in a little bit with what my husband Paul was doing, because he did a study, again, I think it was published in 2021, showed that antihistamines reduce symptom burden significantly in patients with long COVID. If it was as simple as something like mast cell activation syndrome, and you just had mast cells releasing too much histamine, then you would expect the clinical response to antihistamines to be quite quick, because it doesn't take long to block the effects of histamine. And in fact, that's not what Paul and his colleagues are seeing. On the whole, patients are taking 3 to 4 weeks before they start to see a benefit. So it cannot be as straightforward, certainly in all patients, it can't be as straightforward as MCAS. And presumably, again, this is all theory, but presumably there are histamine receptors on T cells and white blood cells. And presumably histamine is modulating the function of those immune cells in some way. So from my perspective, I don't know what's going on quite. I do certainly believe that lots of patients have histamine symptoms, and that's usually, it's multi-system. So you have mast cells, for example, at the barrier between you and the environment. So your eyes, nose, mouth, gut, bladder, genitourinary system, etc. Estrogen stimulates histamine release from mast cells. So as I said, when I started treating long COVID patients, I was quite worried that they'd start to get worse if I gave them estrogen. It was going to be really tricky. And I liaised with some other menopause specialists. Said, have you seen this? Is it a problem? No one really had. And actually, it doesn't seem to be a major problem when it comes to HRT. I probably have had a few patients, can't think of any off the top of my head, that they've had symptoms when we started HRT that could be histamine related. Again, we've just started lower, gone slower, and their bodies have got used to it. And I haven't had any patient give up HRT because of possible MCAS or histamine symptoms.
And it's obviously completely fine to take, an H1 and H2 blocker alongside HRT.
Absolutely. Yeah. Yeah. I
Great.
mean,
Okay.
antihistamines are fairly safe. I've seen a couple of adverse reactions in patients, but broadly speaking, they're very well tolerated.
Yeah. Okay. Fantastic. Um, I want to go to sort of the earlier age group now, because I know there's a lot of women who are still affected, who are absolutely not in what would be the traditional category of 40 plus, susceptible to perimenopause, etc. So what about those women in their 20s and 30s who are going, well, hang on a minute, is this affecting my fertility?
Yeah.
What do we know? What advice can we offer at this point? What sort of route to get reassurance and maybe just some extra advice can we offer here?
Yeah. So I think so premature menopause, or it's called premature ovarian insufficiency, POI, is not rare anyway. It happens to 1% of women under the age of 40, which I think is, as I say, not rare, it's relatively common.
Yeah.
I do wonder if POI is more common in patients with long COVID, because I've
Right.
certainly seen patients in their 30s. I've got some patients in their 30s. Again, there's no data. No one's looked into this in long COVID. Um, from an HRT perspective, or from a hormone perspective, I would treat them in exactly the same way. So I think if someone is young, and they have symptoms of long COVID and they don't know whether they're hormone related or not, then the only way you're going to find out is by doing a trial of HRT. Blood tests are often not reliable. I definitely would do blood tests in someone younger in the hope that they came back positive, because it just makes life easier if you can confirm the diagnosis, but they don't always. So I would always offer a trial of HRT. And if they get significantly better, then really that confirms the diagnosis. And it's even more important to pick up younger women who might have premature menopause, because they're going to be without their hormones for a lot longer. So
Right.
there are lots of associations with premature heart disease and bone disease, etc. Because they if it's 20 or 30 years later, they're going to start getting into that when they're late 50s, early 60s. So you've got nothing to lose from trying it. It's just a hormone. If I was prescribing the pill, no one would be batting an eyelid.
Yeah.
And the pill's got higher doses of hormones, and it's synthetic hormones. They're not as nice as HRT hormones. But young women take the pill all the time and no one worries. But because it's HRT, it has a different association. And so lots of younger women find it difficult sometimes to get their head around the fact that they might be taking HRT. You have to manage each person individually, because it depends on what their priorities are and what they need out of treatment. So for someone who's anxious about their fertility, if I was having this conversation with them, I'd say, look, go and see a fertility specialist, get some advice. If you need to freeze your eggs, if you need to do these things, that's fine. If you're only in your 30s, if you need contraception, you've got a choice. You can either take body identical hormones, which are very safe, well tolerated, etc., or you can take the pill. That's absolutely fine. It depends really what they want out of it. But as I say, a trial of hormones, be it the pill or HRT, it doesn't matter, will give you your answer as to whether there's an issue or not.
Interesting. So you would still be, let me just be clear on this so that, I'm asking the questions that maybe people are thinking when they watch this. If someone still wanted to conceive and they were beginning to notice this more long-term shift in their hormones, what are you recommending here? Are you recommending they try HRT?
So interestingly, HRT transiently can improve fertility, because if someone's got low hormones and you give them their hormones back, then I know in Louise Newson's clinic, they've had a couple of pregnancies that luckily everybody's been very happy about. But so HRT is not a contraception. So I would manage those patients exactly the same as I would manage any woman who I thought might have a premature menopause. If someone is in their 20s or 30s and they, maybe menopausal and they want to have children, then they absolutely need to go and see a fertility specialist.
Oh.
In terms of symptoms and long-term health, they can decide what they want to do about that. And they want to take hormones or not. And if they do, whether they want to take the pill or HRT, that's a whole discussion they can have. Yeah. But absolutely, if you're in your 20s and 30s, then you need to go and see a fertility specialist.
Of course. And I think what I'm hearing from you is, even if you did want to support your body hormonally with HRT, it's not going to have any negative impact on an unborn child if you happen to get pregnant.
No, absolutely not. No, your own estrogen. So if you're taking body identical hormones, normally when you get pregnant, you have estrogen and progesterone in your body. So why would it be any different? If that's in the form of HRT. And in fact, going back to what we were talking earlier with risk of breast cancer, women who have early pregnancy under the age of 20, when your hormone levels are at their highest and your body is flooded with estrogen and progesterone, have a lower risk of getting breast cancer later on. So this sort of distinguishing, that trial that we were talking about earlier said HRT increases risk of breast cancer. There are different types of HRT and there are different hormones. And it's very important to realize, your own progesterone and your own estrogen is not going to give you breast cancer when you get older. It would make no sense.
Amazing. Oh, these are great. Okay, this is good. This is really good, because I see so many kind of worried women posting about what's happening with my fertility. Should I be worried? This is crazy. It's been crazy for 6 months. Am I going to be losing that opportunity to choose to have a child?
Yeah.
It's really great. Okay. So let's go to the other end of the spectrum. I know that there's, this is more uncommon, but still I've had a few people who have kind of flagged it up. Post-menopausal bleeding as a result of perhaps their long COVID infection or their long COVID journey. I know the one person who's been talking about it a few times has had lots of tests, and anything kind of scary and horrible has been ruled out. But is that part then perhaps just of the natural disruption that could have gone on post-COVID?
Yeah, so that's interesting. I've got a few patients that are older. So you're right. The first thing, if anybody's menopausal and not had any periods for a year and they start getting some bleeding, you have to have it investigated to make sure, don't assume it's COVID. You need to make sure it's. But assuming you've had that done. So it's hard to imagine how that can be an effect on the ovaries, because if your ovaries have stopped producing hormones, then it shouldn't make any difference if they get infected with the virus. I'm not sure. I wonder, I know, for example, there are also ACE receptors in the endometrial lining. And certainly when you're having periods, the part where you actually have your period is caused by an influx of inflammatory cells into the endometrium. So it's called the inflammatory stage of your cycle. Right. So whether it's having a direct effect on the endometrium or not, I don't know. I've also had patients with long COVID who haven't necessarily had bleeding, but they've started having night sweats again or hot flushes again or something, which has made me wonder whether it could be something to do with testosterone, for example. So testosterone is a little bit different to estrogen. It's our dominant hormone, and it has lots of effects throughout the body. And testosterone starts to decrease from your 30s. There's a little blip around the menopause because half of your testosterone is made by your ovaries and the other half is made by your adrenals. And I'm wondering, perhaps it's an effect on the adrenal glands. I don't know. So I can't explain it. But absolutely. If you've got post-menopausal symptoms, you've got nothing to lose by trying and some hormones. Yeah.
Okay. So again, you would be, if this person came to your clinic and they'd had all of the kind of scary stuff ruled out, you would say, why don't we try?
Yeah.
Let's see what happens. Perfect.
Yeah.
Okay.
Yeah.
Lovely. Great. Let me just work onto my list here. Just get rid of an incoming phone call. Okay. That's the one around 30s. There was a couple of things that we really flagged up we wanted to talk about. I'm just scrolling through my list here. So actually the Balance app, let's talk about that a little bit more, because I know that quite a few people don't know about it. And I've seen that because someone had posted it into the thread of this whole question. Tell us how you would use the Balance app and why that might be a helpful thing to do, especially if you're kind of worried and getting anxious about what's going on. Because this is something that you can do to start to help yourself, isn't it?
Absolutely. So the Balance app was created by Louise Newson. It's available. It's free. So you don't have to pay for it. You download it. All the resources that are on the Balance Menopause website can also be accessed via the app. So if there's anything you want to know about the menopause or HRT or long COVID or endometriosis or whatever it is, that there will be lots of information. There are some amazing podcasts on the Balance website that you can access through the Balance app that are really well worth a listen to. Lots of things about breast cancer. But also within the app is this symptom tracker. So you can track your symptoms over several cycles. And there is a function at the end that you can download and print off a report that summarizes your symptoms. And you can take it to a GP. And it just saves a lot of time in a consultation. If a GP's got 10 minutes and you take them in and say, look, this is my list of symptoms. I think I need HRT. Then that theoretically should expedite it. And I think that there is some data that shows that women who use the Balance app and take that report with them to their GP are more likely to be successful in getting some HRT.
Amazing. So actually, if you are looking to the point of going to talk about this with your GP, that would be a massive thing. All right.
Well, that'll be the postman.
Dogs, phone calls. We work at home. That's how it is, right?
Ignore that.
Fine. Mine will probably start in a minute. So one thing then that kind of leads on from that is testosterone. Because sometimes people really go, but when I added testosterone, oh, then it made a difference. I'm aware it's fine. I'm aware it's actually quite difficult to get hold of. Tell us a little bit more about why.
Well, shame. Yeah. So testosterone is only licensed in women to treat low libido that hasn't responded to regular estrogen, progesterone, HRT, which I think is rubbish. I think I prescribe a lot of testosterone, and I think of all the things that testosterone can help, libido is probably the last one on the list. And I've had a few women certainly that come back saying it's helped their libido, and that's really brilliant for them. But libido, I think, is quite a complicated symptom. It depends on your energy levels, your illness, your relationship with your husband, your kids, the amount of stuff you've got to do each day, and it's a lot more than just testosterone.
Yeah.
So that's what it's licensed for. Off license, you can prescribe it, and GPs and doctors do prescribe medication off license all the time. This testosterone, it's a regulated product, it's just not licensed in women. But we know that there are testosterone receptors all through the body, and the groups of symptoms that I think respond really well to testosterone are anything to do with the brain. So hot flushes, night sweats, brain fog, anxiety, depression, sleep, mood, drive, all that stuff, headaches and migraines. I think testosterone is good for. I think muscle and joints, so muscle weakness or exercise stamina or joint pains and future bone health, I think it's good for. There are also a lot of testosterone receptors in your vagina and your vulva and your pelvic floor and your bladder. And I think actually it's very good also for treating things like vaginal dryness and painful, if you're having pain when you're having sex, urinary symptoms, recurrent urinary tract infections. I think it's good for all of those kind of things. And that's what I see improving when I start women on testosterone. It's not usually the libido.
Do you know what's interesting there? You sort of describe all of the stuff that anyone would go to get HRT for, right? So why isn't it just part of the package?
I know. If you've never thought about this, so testosterone is our dominant hormone. So it's not a male hormone. They just make more of it than we do. But we make 3 to 4 times as much testosterone as we do estrogen. And until we get to menopause, it's also our dominant hormone. And it's important for all these different functions. And I think the problem is that there has been very little research in terms of randomized controlled trials that have looked at the role of testosterone in treating menopausal symptoms in women, because there's been very little interest. And unfortunately, the guidelines will only consider data that comes from a randomized controlled trial. So all the observational evidence and, a well-designed observational study is far more valuable than a poorly designed randomized controlled trial. But all the observational data is basically just ignored. So that's why it hasn't been licensed for women. And interestingly enough, as a little aside, the evidence in favor of treating testosterone deficiency in men with testosterone is not that much better, but it's a far more acceptable to use testosterone in men. So the FDA have approved testosterone in men, but they haven't approved it for women. So it makes no sense, but it's not licensed for women. Some GPs, because as I say, we do prescribe medications off license. There are certain things we prescribe for pain or PPIs for reflux or indigestion in babies. It's outside its license, but we can do that. Some GPs are not willing to do that. They're not interested. Maybe they don't feel confident, and some can't because it's not on the local formulary. And when you're prescribing medication within your practice, you have to prescribe, the options that you're given. So
but if you went and said, now that you know, oh, it's low libido.
Well,
who's to say that they'll say you're lying?
Absolutely. No, absolutely. I'm not going to comment on that.
I've just spoken to so many women who've said, but my doctor won't prescribe me testosterone. And I'm like, just tell them tell them something else.
Yeah, it's so frustrating. And I think a lot of the lack of confidence is because GPs, because they haven't done it before, they think it's going to be really complicated.
Right.
But it's easier than prescribing an ACE inhibitor, which is a medication that we give out all the time for heart problems, blood pressure. It's less you do a blood test at baseline, and then you start the testosterone and you do a blood test in 3 months. And if it's in the female range, so you're not going to get a beard, you're not going to go bald.
Right, right.
Okay. We're not giving you male levels of testosterone. We're just replacing the testosterone that
Yeah,
you make yourself.
yeah.
And if, as long as you're in the female range, thereafter, it's once a year blood test just to make sure that, you haven't changed and therefore your testosterone has changed, etc.
So this leads me to a question then that is coming up a lot around brain fog. Because, one of the things you said it can really help with is brain fog. And this is such a common symptom of long COVID, of menopause, of whatever the combination between those two things is. If someone were to go and say, can you give me a blood test to test my testosterone levels? And that one comes back quite low and they've got brain fog as a symptom, they can potentially.
Yes, so it's licensed. So if your GP is willing to prescribe it to you because they know a little bit about testosterone and they get it, then absolutely. So, like I said, I prescribe it far more for brain symptoms in long COVID than I do for low libido. Even if women have low libido, it's so far down their list of things to worry about.
I want to remember what I'm saying first.
Being able to take the kids to school is probably more important to them, right?
Remembering that you've got kids.
Yeah, well, you let them. Exactly. So, but absolutely, certainly, I only work privately now, but the products I prescribe in the private sector are the exact same products that I prescribe in the NHS. You're not getting a better HRT if you see me privately versus the NHS. Same HRT, because it's regulated, and I wouldn't prescribe products. For example, I'm not a fan of bioidentical hormones at all. They are not licensed or regulated, and I think they cause lots of problems. But the body identical hormones that I prescribe are what is available in the NHS. And there are some testosterone products available in the NHS. There are no testosterone products available in the NHS that have been specifically designed for women. So in the NHS, you're having to use products that have been designed for men, but you just use a much smaller dose. And it seems to work very, very well.
Yeah. Amazing. Well, I'm glad we covered that one because it's definitely a big issue. I think it's just about having the right conversation with the right GP, isn't it? Okay. I've got a question here around fibroids. And basically, what would be if someone came to you with, maybe a history of fibroids or new fibroids as a result of what's going on for them right now? Is HRT something that they can explore too?
Of course.
Yeah. Yeah. I thought the answer would be yes. I just need to ask.
Yep, absolutely. So most women with fibroids start HRT, doesn't cause any problems whatsoever. Sometimes usually the fibroids don't grow actually. If there is an issue, you can usually treat it. So for example, some women can have the Mirena coil or things to treat the fibroid. Ultimately, and I've not had this, but if I were presented with this, if I had a patient who had a large fibroid and actually it was causing a lot of heavy bleeding by giving her HRT, then treat the fibroid. You have the fibroid treated. It shouldn't be something that stops you from having HRT because you don't want to have a fibroid, not have HRT, have a miserable quality of life and have a heart attack 20 years later. Just get the fibroid treated.
Yeah, great.
You don't need to.
And just out of curiosity, what is it that causes a fibroid? Is that a hormone imbalance or something else completely? I
don't think so. If I'm honest, I don't know much about fibroids other than the role of HRT. But it's benign tumor. It's just a growth. Some women get it. I think it's more common in Afro-Caribbean women. I think it's just luck. I think some women get it and some women don't. But I may be wrong about that.
Yeah. Okay. Well, that's good to know. So here's a question about microclots. If it's the case that microclots are an underlying cause of long COVID, does that mean we are more at risk of clotting issues on estrogen than people without long COVID? Should we be pushing for topical estrogen to be safer or what?
Yeah. Microclots is an interesting one, isn't it? Because in some ways it makes a lot of sense, but there still isn't any proof that they cause long COVID. There's not been any randomized controlled trials, and the technique is very subjective. I know my husband has seen a lot of patients that have been well, not a lot, but a few patients that have been to Germany or wherever for apheresis. It hasn't made much of a difference. So the jury is definitely still out with microclots. It'll be really interesting to see how that unfolds. In terms of HRT, transdermal estrogen, so estrogen that goes across the skin in the form of a patch or a gel or a spray, bypasses the liver and does not increase risk of blood clots. So even if you've had a blood clot in the past, or you're a migraine sufferer and you weren't allowed to have the pill, or you're about to have surgery and your surgeon thinks you should stop your estrogen, if it's transdermal, absolutely not. Perfectly safe in patient. It's all I give, and I see a lot of long COVID patients, and none of them have had any issues.
Yeah.
In terms of oral estrogen, so I very rarely prescribe oral estrogen. There is a small increased risk of blood clot with oral estrogen. That's why younger women on the pill, you have to warn them about risk of blood clots, etc. There's no data or evidence to suggest that if for some reason you can't absorb transdermal estrogen at all, that you can't have oral estrogen. But I know I have one patient that we've talked about because she's quite a complicated patient, and she's too fearful of trying oral estrogen in case there's a link with microclots. And I think you can only be honest and say, look, I think it's highly unlikely that there would be a problem, but I can't guarantee it. So, but transdermal estrogen, absolutely no problem.
That's really reassuring to know. Great. So, okay, we've covered histamine. That's good. So, with diagnosing this kind of thing, so, I know that my experience of it before I went and talked to someone privately about it was the doctor said, let's do a blood test. As we've already discovered, the blood test doesn't really tell us very much. He said, the only thing that I know that is telling me that your hormone profile has changed is because there's an emergence of another hormone that lets me know that there's something more, it's more present in your bloodstream now, that the hormone profile is shifting. And I can't remember the name of it because, of course, I'm menopausal. And I'm fine with that. So, how do people, I know we talked about this earlier, but how do people begin to kind of work out what it is that they need? Is it literally just keep a note of your symptoms, track them?
Look, if you had a 12-year-old daughter and she started her periods, would you take her for a blood test to see if she was going through puberty? Of course you wouldn't. If you're a woman in your mid to late 40s or early 50s and you start getting hot flushes or night sweats or your mood dips or your sleep changes or your periods change, you don't need a blood test. Yeah. It's clinical. It's obvious. It's going to happen, right?
Yeah. Although, can I just say, recently, about 6 months ago, I was in hospital for something completely random and benign. And the doctor there said to me, despite knowing my age, where they were trying to work out what an abdominal pain I had was. And I said, well, look, I'm 50. Chances are it might be related to my hormone profile. And he went, do you get regular periods? This is a young male doctor. And I was on 10 milligrams of morphine, right? Which probably saved his life in this moment. I said, I do get very regular periods. And he said, well, you're not perimenopausal.
Am I allowed to swear?
Oh.
I'm an idiot. He doesn't know what he's talking about.
That's what I thought. And it's really hard, isn't it? Because, of course, when you put your health in the hands of people that don't know what they're talking about, and it's really frustrating because so many women I know have gone there to seek help, wherever it is, and they're perhaps just not met with the right person, which is why this kind of interview is so important because, I lay on that trolley going, I don't know.
Women know their bodies. They know their cycles. They know when things have changed. And it's hugely frustrating to be told by a young male or female or any doctor with confidence that you are, because when you are vulnerable as a patient, you the first thing most women will do is go away and doubt themselves. They won't, their reaction won't be, no, he must be wrong.
Right.
They go, I must have it wrong. And you'll question everything and you'll go back and you just massive step backwards. So ignore people like that. They're really not helpful.
Absolutely. No, it's true. And it really did. The 10 milligrams of morphine did prevent me from grabbing him around the neck, I have to say. The assumption that a woman could get to 50 and not have any idea about her own body is just bizarre.
As well, though. I mean, it's so patronizing, isn't it? Anyway.
It is. So I'm going to come to the last question now, which I think is a really great one. And I've lost it, but I know what it says. So here we go. How can we tell the difference between menopause fatigue and long COVID fatigue? Do people going through menopause have to change their jobs and lifestyle, or is HRT enough to address that? Now, I think both of us as women on HRT could probably answer this question. Why don't you go first?
I'm going to say, why don't you go first? So fatigue. So no, you can't tell the difference. Fatigue is fatigue. I think fatigue is different from tiredness. I think tiredness is something that everybody experiences when they've had a late night or they've slept well. And that's very different from this fatigue, which is, patients often describe it as wading through mud or
Yeah.
feeling drugged. It's, just absolutely having no energy left in the battery at all. It's a very different quality, I think, to tiredness. And no, you can't tell. Yes, absolutely. Lots of women have either reduced their hours or changed jobs or resigned in the perimenopause, or not taken a promotion that they might have otherwise considered taking, etc. It's had a massive impact on women's careers. Whether it's menopause or long COVID makes no difference. I think if you've got fatigue, you can't function normally with it, and you certainly can't work at your peak. So yes, I don't know if that answered your question.
What I would say is, both long COVID and my hormone profile changing gave me an opportunity to change the pace at which I was doing my life, which has been a fantastic gift to myself just going forwards, health wise, emotionally, physically, and everything else that comes with that. So you don't have to change your job and your lifestyle, but actually it is an opportunity to go, do I want to be as stressed as I am? Do I want to push myself as hard as I am? And if we just looked at the menopause piece, it comes at a point where most of us are perhaps at the peak of our careers, parenting 2 children, perhaps, 3 children, however many, not everyone, but, a lot. They're going to be not tiny children. They're going to be going through the teens and exams and all of that. You might even have parents who are not well. You're going to be having a lot on your plate. And actually to be able to prioritize your health and your well-being and your stress levels is probably one of the most important things that you could do. So I would say life change, yes. Lifestyle change, yes. But you don't have to. It's choice. And to support that with HRT is probably just a lovely extra, gift.
I think that's absolutely right. I think you've sort of turned it around very positively there. I think the problem is that a lot of women didn't necessarily want to give up their jobs, or they didn't want to have to reduce their hours, and have been forced into it because of their hormones or their illness, depending on the circumstances. And that's a real shame, because HRT would have helped with that significantly, and does.
Yeah, absolutely. And I do know many women who have gone onto the HRT program and not felt the need to make changes like that anymore, because their brain is back in the room and they don't feel like they're letting themselves down.
It's very different choosing to change your lifestyle and being forced to change your lifestyle.
Yeah.
And HRT just gives you that choice.
Yeah, absolutely. So hopefully that, is offering at least people food for thought around, oh God, I have this thing ahead of me, or maybe I'm in it now. Am I going to have to change who I am? Not necessarily at all.
No, not at all. No, just get help. That's all.
Yeah, absolutely.
Yeah.
So I think, if we were to summarize, this whole thing has been around, inform yourself, know what's going on, know that there's probably not anything specific that's going to stop you from having this conversation to go down that HRT route. Even those who've been worried about breast cancer or endometriosis, there's definitely a conversation that you can have if you find the right person. And there's a lot of information out there. You don't have to have the money to pay to go privately. You can inform yourself, go to that Balance app, read the Newson website. There's so much information there. If you arm yourself, you're going to be much better prepared to kind of, if you meet that junior doctor who said to me, no, you're not possibly, can't possibly be perimenopause. You're going to be ready to kind of sidestep them and just keep going and not be knocked back into a place of, well, hang on a minute. Well, I thought I knew, but you do know. As women, we know. Okay.
Knowledge is power.
Knowledge is power. Absolutely. Well, my goodness, this has been a fantastic conversation, Sarah. I'm utterly delighted that we have covered so many really important subjects, and I just know that there's a lot of women that will watch this and feel reassured. I think there's going to be an extra increase in demand at the local chemist on our resources for HRT. But you know what? We should have the supplies, because this is a big, big deal. So
I completely agree.
Thanks so much for your time. And I'm sure we'll get you back again soon enough to kind of to hear more from the coalface, so to speak. But right until then, have a lovely weekend. It's been a pleasure. Thanks,
Bye.
Sarah. Bye. Thank you so much for listening to the Rest, Repair, Recover podcast. If today's episode gave you hope, made you smile, or even just helped you feel a bit less alone, please subscribe wherever you get your podcasts, and maybe share it with someone who might need it too. So until next time, take care of yourselves and know that you're not on your own.